So placenta accreta is an abnormal placenta, right? So it, when it attaches to the uterine wall, there can be some risk factors that we're seeing more and more of, right? So if you've had a previous cesarean section, or if that placenta then implants there, it can be called a placenta previa. So in women that have had a previous cesarean section and then get diagnosed with a placenta previa, meaning that the placenta overlies kind of the exit area of the womb, that can be a risk factor.
And I would add to what you touched on already, you and I are about 30 years apart from our fellowship training. And back in the 60s, and that was a little bit before my time, the cesarean section rate was somewhere around 6 or 7%. And now the C-section rate, for a variety of different reasons, is somewhere between 32 and 33%. So we're doing a whole lot more C-section, therefore we have somewhat of an epidemic of placenta accreta because so many C-sections are done, and that seems to be one of the strongest risk factors for developing this abnormal growth of the placenta into the uterus.
Yeah, and so with that, with each subsequent C-section, that risk increases for there to be a previa and there to be an abnormal placenta. And when we think about that, that placenta can grow through that previous scar defect of where they had their C-section. And when we think about that, it can actually go through the muscle of the uterus or the womb, and also then to the bladder or other surrounding organs such as bowel, vessels. So these can be more complicated and riskier surgeries.
And those surgeries are truly potential emergencies. These placentas can get very aggressive and grow into blood vessels and be involved with a significant amount of blood loss. But the importance of that is that we need to have a multidisciplinary team to have a group of people that are capable of taking care of this.
Right. So most importantly is finding it early. Usually we'll diagnose that on ultrasound, and then getting that patient tucked into our care, and then throughout their pregnancy be able to follow them, get the other teams involved. And as you talked about with multidisciplinary teams, we think about not only maternal fetal medicine and the obstetrical provider, but also anesthesia. The blood bank is very important, and pathology. Our nursing staff to coordinate these complex cases as well. And so yeah, it really kind of, neonatology, our ICU team, so really just kind of brings in everybody from different areas of the hospital that all kind of converge on this patient or on this case.
Yeah, I think that's all very important. I think to add to that, the case that you and I did with a young lady whose first name was Brittany, she was not from Baton Rouge. She was from Monroe, Louisiana, which is 4 hours from us. Our group of maternal fetal medicine specialists goes to many different areas of the state, and we feel like that's a big benefit to the people of Louisiana, where we can take somebody like Brittany, who was in Monroe. She had some bleeding. We brought her to Women's Hospital. She was on our high-risk unit for a period of time, and then we were able to do a C-section in a planned fashion with the hysterectomy, you and I with the resident, and fortunately had a good outcome.
So Brittany got originally diagnosed with her placenta accreta up in Monroe. She had presented to the hospital there with some abdominal pain, which subsequently led to ultrasound and an MRI that was performed that ended up giving her that diagnosis. She stayed up in her hospital for a brief period of time, and then her doctor felt that it was imperative to go ahead and transfer her to a higher level of care. So she got transported here to Women's Hospital, and that's where I got to meet her for the first time. We also performed another ultrasound and looked at her. And then I really got to just kind of sit down and diagram everything out with her, talk to her about her diagnosis of a placenta accreta. Her main risk factor is that she had had one previous cesarean section, and that the placenta was also a previa. But fortunately for her, she was able to remain stable and was actually ultimately able to be discharged back home, where then she continued to have follow-up with us at the Monroe office.
Then I got a phone call late one night from her referring doctor, who said she had a significant bleeding episode. And her two concerns were that they felt like our team would probably be more appropriate to take care of the patient because we had all the parts of the team that needed to be there, but more importantly, their hospital was low on blood. So we discussed the pros and cons of transport and ultimately decided to bring her down on a helicopter, which went fine. I met the patient in the hospital, and she actually had stabilized very nicely. And then fortunately, she did not have any significant bleeding episodes, and we're able to do her a couple weeks down the road on a planned date that we originally had picked out.
So the day came for Brittany's surgery. Prior to that, we had talked about with anesthesia to allow her to have regional anesthesia for the delivery of her child, and that's really beneficial because sometimes these cases, these women will ultimately end up going to the ICU, and then they're not able to see their baby for potentially up to 24 hours. And so, we took her to the OR. She was able to get regional anesthesia with an epidural, and then, we proceeded with the case. And the interesting thing with that is when we entered into her abdomen, the placenta was essentially just staring us right there in the face. It had actually grown through the uterine wall at her previous cesarean section scar, and that scar had already opened up. And so we already had all the necessary teams in place, and she had been prepared to have a massive blood transfusion if needed. And so we had all of those aspects already ready for her, but it was surprising when we got in there that it was maybe a little bit worse than what we had anticipated upon entering into her.
I certainly was surprised by the dramatic picture of that placenta coming through where her prior cesarean scar had been. And it got moved a little bit at the time we're trying to get the baby out. That was made a little bit more complex because the baby was in a breech presentation. We had to kind of maneuver around to get the baby out. I think the other thing I'd point out was that these cases are complex, and therefore we had two seasoned surgeons there. We had the two of us who've both done a lot of these types of cases, and I think that's very important, that you need to have really a surgeon with as much experience as possible being there, because it just makes things go a lot more smoothly.
And I think the thing to touch on with that as well is that it's not just a standard C-section and a standard hysterectomy as if they were two separate entities, right? So with this complex case where the placenta is there at the bottom and it embeds out and then it balloons out, it makes doing the hysterectomy more lateral, which is closer to blood vessels, which is closer to the ureter, and injury to the bladder. And so it takes a different skill set to be able to kind of maneuver through these cases.
And I think part of that skill set is patience. You can't let the ongoing blood loss make you go faster than you should. In this particular case, we were slowed down while there was some ongoing bleeding because the bladder was so closely applied to the uterus, and that is fairly common with placenta accreta. But we may have had to give her a little bit more blood, but we did everything safely, and ultimately, post-delivery, she did very, very well ongoing until she got home.
And our anesthesia team, I felt like, was just very on top of the blood loss. They were going ahead and giving her blood products along with our blood bank. And so it's nice to be the surgeon, being able to focus in on the patient and the surgery that you need to do at hand, and know that there is another team there that's behind the scenes that is making sure that she is getting the appropriate blood products that she needs as well. And so yes, so during that time, as you said, she did have some bleeding, and ultimately it did require a massive blood transfusion. And when we think about that, ultimately at the end of the day, we essentially replaced her entire blood volume that she had coming into the case. And so,
absolutely, yeah.
Again, the facilities here at Women's Hospital allows us to take care of these complex cases.
Women's Hospital through the years has done community outreach, and currently our group of MFMs travels the state. We go to Monroe, to Lake Charles, to Thibodaux, to the North Shore, and to Hammond. And we have a presence at all these places where we can identify patients with problems. In this case, in Monroe, we were able to identify Brittany and fortunately get her down here to Woman's and have her care. And so this is available. We've been going on outreach for over 15 years now. But it's just recently that we have been trying to get more cases of placenta accreta and then we're more involved per Accreta. So we feel like we have our team here, and ultimately we'd like to be designated as a center of excellence and be happy to take care of any woman from Louisiana, any woman from southern Mississippi that's near us, and take care of that geographic area of patients.
I think by becoming a center of excellence here, you have to have the multidisciplinary team in place, and we're set up to have that. We already have anesthesia, our NICU, our blood bank, surgical specialists, our subspecialists, even if we need those, here with maternal fetal medicine and our obstetrical providers as well. And so by coming together and putting all of our resources together, we can best take care of these patients. And so just like you said, not only here in the Baton Rouge area, but to try to allow access for women across the state and across state lines to be able to come and have care here with us.
It's like anything in life, the more frequently you do it, the better you get at it. So you have specialists in things, and this is what we want to be as a specialist in placenta, Accreta, the treatment, and be a center of excellence.
And this is near and dear to my heart. This is truly one of my interests and surgical expertise. In my fellowship training, got to do many, many cases, approximately 15 to 20 a year. And so when you think about that, just having a team that's able to do a lot of these cases, not only are you going to help improve that woman's life and outcomes, but be able to just provide even more resources for the entire state.